In this last session, we get to dream up new and ever more cruel ordeals. And we have three experts here who can talk about practical implications of the theoretical discussions we've been having, ordeals in practice. And you already know who each of them is, so it just remains to ask Jim to give the first comments.
So I'm going to try to make some practical points, and I'm going to do it in the form of three assertions, oversimplified assertions, but following Harry Truman's advice, he didn't want one-armed economists because he couldn't stand on the one hand and on the other hand. And my qualifications for talking about this topic are that I'm both a physician, so I've experienced ordeals there, and I'm a patient. So I've experienced ordeals in that setting as well. Okay, number one. It's a practical question as to whether there is any rule or divining rod that will tell us when the ordeal mechanism is useful or ideal and how to apply it. And the answer is there's no such thing. There's no rule. Yesterday, from Elizabeth and Kristen and Shari, we could distill from what they said the view that we need to think about ordeals as part of a managed strategy. The key guiding principle is what are the goals we're trying to achieve, and what is our management strategy for achieving those goals? And in the context of doing that, we can ask whether and in what way this form of specific tool, the ordeal, might be useful. So, as an example of what's required, I'm going to take up what Richard brought up yesterday. So Richard told us that in some work he did, he found that 15 drugs accounted for 30% of the Medicare Part D expenditure. That's a perfect start to the strategic process. 15 drugs, 30%. There's a lot of leverage in a relatively small population. What should we do about that? As a thought experiment, Richard made a proposal which, in contrast to identifying the 15 drugs, a proposal that is ideally unsuited to achieving the result. Namely, let's put impediments to the physicians. They have to write for 20 minutes or 3 hours in order to get the drug. Now, there's no question that 15 drugs that produce 30% of the Medicare costs, Part D costs, it needs to be managed. How should we do it? I think if we picture the CMS leaders talking about this, what are they going to do? They're going to say, these drugs are complicated, and the conditions that they're for are difficult to treat and subtle. We don't want every Jane and John prescribing them all across the country. We need centers of excellence. Let's identify places that use the right clinical criteria, take into account efficient management, blah, blah, blah. Or they might say, for 6 of the 15 drugs, there's good evidence about when they're useful and when they're not. We're going to establish rules. You have to have A, B, C, and D to be eligible for the drug. And adjoined to that, because there are always good reasons for exceptions, we'll have an appeals process. The appeals process is a pain in the neck. It can be thought of as an ordeal, but it also is a learning opportunity. it may bring new evidence to the surface. So, point number one, we don't have general rules, at least at this point, for how, when, and why to use ordeals. We need to think of them as an acceptable in principle, but subsidiary component of strategy. Number two, given that there are no rules, I think we can take Charles Fried's emphasis on transparency as a piece of guidance. And I will assert that as a default principle, we should assume that if we are going to apply an ordeal process, there should be full transparency about it. Now, the reason for that, we could infer from the previous presentation on modeling. If you think of the slides that were up there, the slides dissected out dimensions of the process involved in making choices and directed our attention to them. That's what transparency would do. We have to be prepared to justify, explain, and educate about why are we doing this thing that we're doing. As one little subsidiary point, I would say to, I think all three of the authors of the paper are still here, Ordeals is a great title for a philosophical paper. It's a terrible, terrible term for discussion of health policy. So I would advise drop the term, keep the background idea, but don't subject the population, the general population, to debate about ordeals. It will be counterproductive. Finally, as my third point, we've talked about ordeals as applied to the population of patients or potential patients and to physicians. I'm slightly nervous about what I'm about to say because it is susceptible to being attacked as a piece of physician arrogance. But my view as both a patient and physician is that ordeals are in principle acceptable for the patient population. I think they're a terrible, terrible mechanism for physicians. Why is that? When I'm kept waiting in my physician's office, which, like everyone here, I have experienced, it's a pain in the butt. But frankly, it's not a very big deal. It's a relatively minor annoyance. It is an annoyance. When, as is true for physicians in full-time practice now, their work life is altered very substantially. So there are phrases like pajama time. Physicians will do their electronic medical record work at home when they've done the ordinary day's work. The AMA has quantified the impact of the multiple mechanisms that are at work in our effort to use the market to regulate medicine. And taking Julie's concept of free time, they have devastated free time. So an unintended but very real side effect of using market mechanisms to regulate physicians has been enormously counterproductive. Burnout is a very overused phrase, but it's a real event. And physicians are cutting back on their time, leaving practice, which undermines our objectives for the health system. The reason for being disturbed about using this mechanism with physicians is not physician authority not to be managed in any way. It's that in empirical terms, the use of the market has extremely high costs on the medical system. So what should we do there? 30 years ago, okay, 30 seconds. 30 years ago, there was a paper, Reins versus Fences, which made the argument that the way to manage physicians is not to try to rein them in by ordeals, but to fence them in with a budget, a population they're responsible for, monitoring of quality outcomes, and autonomy to pursue the ideals of medicine within those constraints. Thanks.
Thank you very much, Jim. Chris?
A second? Okay.
Oh, no, I'm sorry, Peter.
Either, I'm indifferent. You want me, I'm here? You want me to go
Peter,
into it?
but no, let's do it
Okay.
by the book.
Okay.
My mistake.
Go to the boss.
Okay, thank you. Well, thanks for the chance to add some thoughts to this conversation. I've learned a lot of different ideas from people not normally in the fields where I work. So I'd like to really touch on two things with a little intro. The first being more what I take away from some of the practical implications of what we could do to improve our understanding of and use of these kinds of mechanisms. And the second being some observations about the practical consequences of thinking about the right to health and how that relates to these kinds of consequences. I do want to start off briefly, though, endorsing James's idea that using the term ordeals, I think, is very counterproductive. I think that, and I think Richard started us out yesterday basically saying, if we fundamentally believe that everyone has a right to health and health care, then there's nothing to talk about in terms of ordeals. And that, in other words, ordeals are wrong, okay? So using that term really does kind of start us off in that place. And I would argue that that's not a very good place to start a conversation that has a complex public interest and public policy discussion. So let me first then now focus on the questions around sort of some of the more practical things about what we can do about ordeals, and I want to start about these mechanisms. I'll try not to call them ordeals, and I'll start again with Richard's comment yesterday that if we fundamentally start with the belief that everyone has a fundamental right to health and health care, then there should not be any of these mechanisms being used. Everyone should get what the World Health Organization originally called universal health coverage, which is access to all the health care they need at a good level of quality with no financial hardship. Okay? That's a very nice idealistic view about actualizing this right to health and health care. But we're not in that world. We're in a world where there are many departures from that ideal. And if that is the world we're in, and if we in some way are willing to accept that, then we talk about these mechanisms that we have to deal with to make better use of the resources that we have to achieve goals around health and health care. So I think what we've heard a lot of in the last day have been many specific aspects of that, and I think of them in two dimensions. The first is which kinds of mechanisms does it make sense to work on and use? And the second is how do we consider the different values that we would bring to analyzing or understanding the impact of these mechanisms, okay? And so the first of these, I think, is a very important area of empirical research, and we have a lot of research going on in this. And this is basically the question of how do people respond to these different mechanisms? If we introduce waiting time, if we make it difficult to get things, different mechanisms like vouchers and so on, what's the empirical observation, measurement that we can do of the response, and how is this response distributed amongst different people in the population by age, sex, by poverty level, or whatever are the factors that we care about distributively. And I think that's good. We need to do a lot more of that because we often are implementing these kinds of mechanisms without really understanding well what is the impact of them, and certainly in a distributive sense, what's the impact of them. And we heard a lot about context. That is, we need to understand very much how these mechanisms work in different places with different people and so on. So that work is underway. Probably need to do an awful lot more of it, but it is, I think, a fairly clear way forward. The second part of this work is the valuation of the impact of these things, and that gets us into some pretty treacherous ground. And here we see this conversation between economists and public health people as, I think, one of the classic examples where, economists would say, well, we care about how people perceive or value the impact through this utilitarian calculation, whereas often medical and public health people say, well, I don't think people really understand the value of these things. I care about whether it improves their survival or their functionality or whatever. So we should adjust these mechanisms to achieve these, what I would call more objective, what some would call more objective goals, or at least goals that are different from people's subjective perception of what is important and what they need. And that discussion, we heard a discussion about time, for example, some kind of a right to time, which is an example of this kind of assertion of other dimensions of things that should be valued other than just the utilitarian observation. And then, of course, the big Achilles heel, and I'm an economist, I'm a pretty lapsed economist, I'd say. The big Achilles heel of the utilitarian perspective in economics is that it almost always abstracts from the starting position of individuals in society, which is very unequal. So it is very difficult to simply talk about people's preferences without really understanding their position in society in terms of their income, their wealth, their opportunities, and so on. And this inequality fundamentally alters how you would value this, what you would empirically observe from people's preference behavior. So it seems to me that we have a big empirical agenda. We have a tough valuation agenda. I think we have a lot of things to work with in there. I've never seen particularly, coming back to James' comments about there are no simple rules. I've never seen simple rules for solving the valuation agenda. And I would only add the comment that transparency, while it is a nice objective for academic discussions, is often not a very useful objective for policy discussions. In other words, telling people why you're really doing things, I think is a value I believe in, but it might not actually get things done in practice. And that's an important thing to keep in mind. So the last thing I want to talk about, and this is what I kind of, if I can bring anything new to the conversation, I'd like to come back to this question about the right to health and healthcare and turn the conversation around a little bit, particularly in the sense that much of the assertion of the right to health and healthcare actually results in ordeals. Okay, so I'd like to put that supposition out there. And this is the sense in which I mean it. When one asserts a right abstracted from the means to achieve that right, the consequence is ordeals. Okay, and we see that in many examples around the world. For example, the huge interest today in universal health coverage, which is resulting in lower and lower middle income countries number of them advocating universal comprehensive health insurance, putting that in place without the means to finance the health care that's being promised to the populations. The results, denial of care, waiting times, user fees, things like that. Another example, more from my work again in developing countries, has been the movement to abolish user fees in many low-income countries. Now, user fees are a terrible way to finance healthcare from the point of view of sharing risk and putting the burden on the sick and so on. The only thing that may be worse than user fees is having no care at all. But in many countries, that's the actual choice that gets made. So it is true that many low-income countries have abolished user fees and that utilization of services does go up in response. But there are cases where the consequence of that increased utilization is simply the absence of resources to deliver care, hence ordeals that result. And then James shared with me another example, which I think from the United States, which I think it's worth mentioning, which is our solution to the underinsurance problem in the United States, which is to guarantee that all people who have an emergency medical need must receive it in hospitals, which has led to public hospitals facing a huge amount of uncompensated care, which they have to somehow absorb, taxpayers not wanting to pay for that. Consequence, ordeals, waiting lines and denial of care and so on. So what this leads me to conclude is that we can't simply put the burden of, we can't simply think about the problem of ordeals is how to relieve ordeals that are unpleasant or that we don't like in order to improve the access and fairness of healthcare. We should think about that, but not only that. We also have to be responsible if we're going to come back to Richard's assertion that that if one wants to assert the right to health and health care, that therefore one has a responsibility to do that in relation to the resources that might be available. And it isn't good enough for those asserting that right to simply say, not having those resources is wrong, it's somebody else's problem. We really have to come at this from both directions. Thanks.
Now, Chris.
Good afternoon. I thought I would contribute to this session on the practicalities by sharing some data from a rationing through inconvenience scheme that's been put into practice. This is from the paper with Nir and Paul that we worked on for several years and came out just in January in the Hastings Center report. And someone once told me, and I've come around in my scholarship to realize that often a single figure is more powerful than an entire book of words, and so I've more and more spent time trying to figure out how to communicate things visually. And to do that, I found this data set from the secondary literature, Teagarden et al. 2012, that reported 38,621 applications submitted by physicians to a pharmacy benefit manager who had a special program, an example of direct rationing, that for certain drugs that were used off-label, an off-label indication is one that a physician seeks to use for some purpose other than what the FDA has specifically reviewed and approved as safe and effective. It's quite common, as you may know, in fields like pediatrics to use drugs off-label, but also because many drugs haven't been tested on children in particular, but it's also quite common in oncology. Cancer drugs, for example, might be proven effective for colon cancer, but might be used off-label for pancreas cancer. So this particular pharmacy benefit manager has said, well, if you want access to these very expensive drugs off-label, you have to ask us first, and we will tell you whether you're allowed to give it to your patient. And so it really is a form of direct rationing in that sense, or at least it purports to be. So each of these little icons represents 386 of those patients, 1% of them whose physicians submitted one of these applications. But I want to sort of like parse out what happened. And the first is that we have to acknowledge that there is an unknown, in this data set, there's an unknown number of patients and their physicians who declined to even apply. Even though the physician would have otherwise, in the counterfactual world, if he could just write the script, he or she would have just done so. But knowing that they had to go through an application process, just said, never mind, let's just do it the faster way. Let's just do it the simpler way. And one observation here is that's not going to be in the data set of the people who actually applied. But it's a huge question mark because it actually may be a larger effect of this policy than what we do see. So I've just put a speculative number of suggestive figures there. Going back to the 386,000 applications, going back to the 38,000 applications that were submitted, I want to highlight that all of these people then suffered an inconvenience. They suffered time. It was, at the very least, the patient suffered a treatment delay, and the physician suffered a paperwork delay, probably also suffered other administrative costs of either picking up the phone or typing in the information. Okay, what happened to those applications? Well, it turns out that 90% of the applications were actually accepted by the pharmacy benefit manager. Isn't that interesting that this pool, right, you think about the false positive and the false negative rates, the physicians were actually doing a decent job, it looks like, at screening in advance before even submitting these applications because 90% of them got a yes after the physicians and the patients suffered that inconvenience. Of those that got a no, the 10% in this data set, where the applications were denied, what happened next? This is a really interesting effect right here. It turns out that no appeal was filed for 6% of the total number of cases. So 60% of the cases, even though there was an appeal process, the physician and patient declined to even pursue that. This is for a drug that, keep in mind, yesterday they thought was the right drug for this patient. The physician thought so enough to undergo this application, but upon receiving a no answer, is like, okay, I'll give you this other drug that I didn't think was as good as the one I'd recommended for you. Second, so this is a second effect here of rationing through inconvenience, where it's deterring consumption of the patients. So in 4% of the total number of cases, an appeal was actually filed, and here's a second layer of inconvenience being suffered here, picking up the phone again, or filling out the longer form, or generating the extra lab tests they wanted, or calling for a secondary opinion, all the additional pieces that could go into that appeal, creating more suffering or delay. And finally then, it turns out in this data set, less than 1% of the cases was the appeal rejected, and that's what I would suggest is the pure case of direct rationing, the pure case of centralized allocation, whereas in 3% of the cases, those appeals were ultimately granted. So if we put the whole picture back together, you can see that of these 38,000 cases, less than 1% of them were examples of direct rationing. Although this is an example, the scheme as a whole, we might think, is the paradigmatic case of direct rationing. In fact, the way it actually functions is mostly indirect rationing through these sort of attrition along the way. And you can also see, if you compare the orange people here, I don't know if you can tell if they're orange, and the orange people there, those are the ones who didn't consume because of RTI, rationing through inconvenience. At the very least, there are a multiple of 6 or 7 times the people that didn't consume because of the direct rationing. Okay, so what can we glean from all of this? And I'll be done here. Is first that direct rationing schemes may be mostly rationing through inconvenience, and that in fact, in the real world, in the practical world, we're going to be dealing with hybrid schemes. So not only was this direct rationing and rationing through inconvenience or ordeal, there was actually a price on these drugs too. So we were also using a market mechanism. So in practical terms, to disentangle the effects of all three of these, and each of those have a different gradient of selection to keep in mind. And I just want to emphasize here, we've been using the word ordeal and inconvenience kind of loosely for the last 2 days, where, oh, you suffer an inconvenience as distinct from where the inconvenience causes someone to not consume. But I want to point out that this inconvenience did cause a lot of people to either not submit the application or not appeal the application. So it was actually the inconvenience affecting the consumption pattern. So it really is RTI in that strict sense. This also has highlighted how potential inconvenience can reduce consumption, how RTI can inconvenience even those who do not consume as well. So we don't normally, so it's not merely the person themselves walking to get the chlorine tablet, they suffer the inconvenience, but rather the inconvenience can apply to others as well. I highlighted the point that the biggest effects may not be observable in the data set. And the last sort of point I haven't emphasized yet is that rationing through inconvenience for physicians, when the physician faces the inconvenience, it really can worsen what economists and law professors call agency problems, where the physician is supposed to be doing the bidding of the patient as her agent, but in fact the physician is going to bear those costs for which the physician does not receive a commensurate benefit. And so this creates the classic problems wherever you have an agency relationship of shirking, where the physician may not invest optimally as he would or she would if she was there to reap the benefits for herself. That distortion is another form of conflict of interest, counterset by other situations where a physician is a self-referrer or has a side deal with the drug industry, for example. So I think that's an interesting additional point, is how rationing through inconvenience ordeals can create or exacerbate conflicts of interest. Thank you.
Thank you very much. Do you have a comment as the inventor?
I have two comments.
Yes.
First, the United States doesn't let you easily renounce your citizenship. Peter, the economics profession does not let you easily renounce your profession. You made a point which I think is very important, which is not often made at an ethics conference, that when you assert a right, you have a responsibility to consider where the resources are going to be provided to meet that right. I consider that to be an ethical pronouncement. But I should say I've been in many ethics conferences where your statement would make you go to the doghouse. And you sounded just like an economist, and I'm not letting you out of the profession. Okay. My second point is about transparency. I'm an economist. I think there's almost always a trade-off. Now, Peter and James both told us that we shouldn't use the word ordeals. Now, maybe I'm just too stuck in this. I've been living with this word for about 36 years in this context. I believe that if you really believe in transparency, you should say what you're doing, which is you're putting a burden on people. And we could use the term targeting mechanism. And nobody would quite know what that means, but we would eventually get around to it. But I believe we once had a guy named Fred Kahn, who used to be sort of like an economic czar for the country. He said, you're not allowed to say inflation, I'm going to call it bananas. If you don't call an ordeal, or a burden or source or any other thing that really imposes that you're imposing something on people as a sorting mechanism, just what Christopher was talking about, I think you're not being transparent. Okay, second point about transparency, I don't think it's nearly as a pure desired good as your comments would seem to say. Let me give you an example. One of the things that people have talked about here, I thought quite insightfully, was the idea that sometimes when you impose an ordeal, there's a certain stigma or taint that goes along with the people who incur the ordeal. One of the things that we should think of is there a way to make an ordeal just as effective in a sorting mechanism, but having much less of that sort of taint? Let me give you an example. Rather than have people wait in line, say there are now miraculous new bed nets. Rather than having to wait in line for that, they could help build a storage facility for the bed nets in the area. Actually, we don't need the storage facility, posit. All it's doing is it's letting the people we're building something for the community, complete sham, but it restores their dignity, it makes them feel good as though they're contributing something else. I would argue it actually, to some extent, reduces the dead weight loss. And also, as was pointed out, there are many experiments that you can't do with complete transparency. Some of my friends talk about, run experiments where they subsidize more nutritious foodstuffs in one village as opposed to another to see whether it alters consumption. You want the village which is getting the more nutritious foodstuffs at a cheaper price not to know that they're being subsidized, because if we're ultimately going to do that, we may not want to know, or we're going to create new seeds or whatever else it might be. And you certainly don't want the people who aren't getting the nutrition sort of saying, hey, no, wait, the people over in Village A got this for $1 and you're charging me $3. So I just want to point out that there's always a trade-off with something good. Transparency is something good. Transparency is something bad, some of the time.
Responses by any of the speakers or others?
The way I think about transparency here is that since there's no rule to tell us when an ordeal is desirable or effective, the equivalent of the front page of the New York Times or Boston Globe test can be useful. Because when we think of explaining what we're doing, we have to take account of the different dimensions that are relevant to assessing the ordeal. Will it increase disparity? Will it diminish dignity? And in having to think that through and see whether we can speak for the ordeal with a straight face in public, that's how I see the transparency as valuable. Not as a simple good in itself, but as a kind of litmus test, rule of thumb test for the general ethical acceptability of the ordeal we're considering.
If I can throw in another consideration along those lines, think about the lack of transparency is that it's not enough for you to disguise the truth. You have to often get the people who are going to be out there implementing all this to go along with this. That means that you may not be transparent to them. You want them to stand up and defend the practices that they've been told to defend, and the best way to do that is to convince them that these are inherently good, when in fact you don't think they are. That's all just a pose. That may not work out too well. First of all, they might start upholding those false values in other cases because you've told them that they're worth upholding, and they don't apply, and people can get their stories crossed, and that's tripped up some of us in various contexts. Last month, if I could just mention, there was a big conference at the medical school on the definition of death controversy, in which I personally played a role. I had the title of staff philosopher at a presidential commission that introduced the redefinition of death to include brain death. Now, I was convinced back then that people who are brain dead aren't really dead. They was just playing around with words, but I thought it would have a good effect to say that they were. And I went along with it, and I even wrote the text that tried to pull the wool over the eyes of the public, and it succeeded in part. But it's been hell to pay ever since. So it's not just a one-time fib. It can come back and bite you. Anyway, other comments? Okay.
I'll just mention, when Nir and I and Paul were writing this paper, we struggled both with the word ordeal, and the word inconvenience we decided to use. But of course, the word rationing also is one that Americans aren't even able to use without their head exploding. So, you want to be savvy about transparency and not, make a fetish out of it in a way that isn't really going to serve the conversation.
That same presidential commission that introduced the brain death thing, we put out a long report on access to healthcare in America. And after working on it for a couple of years, we were told that it was not going to be printed. The White House was blocking it. The reason was that we had the word rationing throughout. So we went through and changed it in each case to allocation and went right through. No problem.
Allocation of scarce resources.
Yeah. Peter.
Yeah, I just, first, Richard, thanks. I didn't burn my card just yet, my economist card. But I wanted to take up the question that James raised about whether these mechanisms, somehow physicians should be more exempted from these mechanisms than patients, and I guess take issue with that assertion. So if we look at all the relationships in healthcare, there are all kinds of incentive and principal-agent relations between patient and physician, between physician and insurer, between patient and insurer, and so on. And there's plenty of evidence that that these relationships don't work perfectly in the interest, left alone, in the interest of any of the parties, okay? There's plenty of examples where, for example, physicians are perfectly happy to abuse the insurance companies because the patients would like them to, for their convenience, right? Which does impose a social cost on all of us when that happens. So I think we do see this. I don't see a priori a strong reason why we should exempt any group in this market from these mechanisms. But I do think that we have to pay attention to the consequences. So if the mechanisms result in a whole class of highly desirable professionals saying, I'd rather go into private equity than treat patients, then that's a bad thing, and we don't want that to happen. At the same time, I think this discussion here in the U.S. is pretty colored in the sense that U.S. physicians are paid better than physicians almost everywhere in the world. And I often hear this argument that, this is not a good use of my time, or the pajama argument that you made and so on. But, part of what we see in the market is that providers, it's very financially beneficial to providers to probably take care of more patients than they should in order to achieve the incomes that they feel they're entitled to. So there's a lot of things in this relationship that could be adjusted, and we do see different things going on in different parts of the world.
Can I jump in again, if I'm a member of this inner circle here? Again, coming back to the transparency business. Think back to the old, still renowned RAND study of copays done by Newhouse and so on. So what they showed was that if you have a insurance pool for health care and you impose a modest copay, not in order to share the costs, but in order to deter people from making use of resources when it really wasn't worth it. The result, except for the people who are poor, is that the costs go down and the apparent value of the services are unaffected. So that was a landmark study. It's probably the most famous health policy experiment that was ever done. Now, what lesson should ordinary citizens derive from this? It seems to me, maybe I'm wrong, maybe somebody can show me my mistake, but it seems to me what the ordinary citizen should think is, I'm going to look for a insurance scheme, if I'm buying health insurance, that institutes a modest copay, because I'll get lower rates and the quality will be good. If I enter one that has no copay, the rates will be higher without any corresponding gain. This is, again, assuming there are provisions for the poor. Now, that would mean that the copay, let's think of it as a kind of ordeal, although it's obviously a price one, that the copay isn't onerous, it's actually something that I would think is something that's good for me. I want, not because I like the copay, but because I want all the other people in my insurance pool to have it. And since what they do affects how much I pay, the fact that they have this constraint on them is something I have to think about, and I'm in favor of it. Okay, so here's a case where having an ordeal, or at least a constraint, having to do a copay, to someone who has understood what the RAND experiment showed, would not be seen as a burden. It would be seen as highly desirable. In fact, I would, if there were a choice between two plans, one of which had the modest copay and one of which it didn't, I would probably choose the one that had it. So thinking back to what Richard said at the outset yesterday, the thing about ordeals is it can result in having more. It can result in giving more benefit to people who need it. And so in that way, it stretches resources further than what you could do without ordeals. And if we think about the educated consumer of health insurance, at least, or anybody else who might be subjected to a inconvenience or some kind of modest ordeal, if they think in the terms I've just described, they far from resenting it, they would think, oh, this is just what I want, because we're actually increasing the size of the benefit or the resource for a relatively modest cost in terms of time, even though there may be some deadweight losses. Well, if everyone thought that way, we could be totally transparent. We could educate people, just give them a little introductory economics and explain how this works, so that everybody would be saying, I want ordeals, damn it. Now, where are the ordeals? You're going to be wasting my money unless there are some ordeals here. I have to constrain those other guys in my insurance pool. But of course, that's not the way the public sees these things often. So could we hope to achieve greater transparency simply by more patient and extensive educating of people about why it's in their interest to have these inconveniences from time to time, because it lowers their prices and maybe increases their access and the quality of services and so on. Or is this just pipe dream? Maybe there's just a tiny number of people in the public who could ever really grasp this, and for everybody else it's just, I hate it.
Well, I like this because it would increase employment for economists.
Yeah.
And I also want to caution you, because you're drifting towards Peter, and you might be drummed out of the philosophical ethics profession. We hijack you and take you into our own.
Oh, okay. Then
The last statements that you made would be considered very inflammatory in many
well, I take them all back in that case.
So the only asterisk I would put on that is that a lot of knowledge, policy relevant knowledge, I think is actually implicit. It ends up being built into our culture, built into our parties, built into our subcultures geographically. And so, phrases like, no freeloaders or people should pay their own way if they're able, are, rules of thumb that can encapsulate this more sophisticated and complicated economic reasoning, but actually get to the nub of it. So I'm not sure you have to educate every person on the economics themselves so much as bake these sorts of things into larger political agendas and political cultures even.
Dan, can I just make an observation? I preach this not vis-a-vis healthcare, but vis-a-vis auto insurance to my students. And almost all of them switch from, a $500 deductible to a $2,000 deductible on their car to mix themselves in with more careful drivers and to avoid the extraordinary administrative costs associated with having the adjuster come out and argue with the company and the fraud and everything that goes with it. Seems to be a lesson that people, at least in the auto insurance context, but they don't have this other emotion about healthcare sort of that goes along with it.
And yet, a lot of people have the $500.
A lot of people have it because if I were an insurance company, I'd like to have a lot of people have it.
These are Harvard Kennedy School students, right?
No, I'm actually dealing with, I pick up the guys who are sort of wandering around Harvard Square asking me for money. I say, you'd have more money if your auto insurance were at a higher deductible. It works terrific.
Well, that's great. If it works for them, Other comments within or about anything? Near.
Just following what Dan said, a thought about potentially educating the doctors about this. So it's not just the general public. Part of the very bad effects of ordeals that doctors experience in terms of burnout and leaving the profession, which is indeed a terrible outcome, may have to do with doctors having the wrong expectations in the first place, because they left medical school with training that told them it's going to be about touching the patient's body, never about
Filling out forms.
Filling forms is not what medicine is about. And the future of medicine is going to involve, even setting aside rationing, a lot of reporting, a lot of coordination with colleagues, a lot of typing, in your pajamas, or I don't know, we should find some way. And partly this burnout, demoralizing and burnout, may stem from a infantile conception that we're instilling and are continuing to instill in our education about what it makes sense for the future doctor to do. If we were better at preparing people for what actual practice will be, including teaching people about rationing and the need for it, for a better healthcare system that they want, and if we thought that in particular cases, ordeals are the least bad way to get there, maybe some of the burnout would not be there.
This is an area I've been involved with teaching medical students about for a long time, and there's actually been quite a change. The students have moved from thinking that rationing or for a physician to consider cost is deeply unethical to seeing it as part of the physician's responsibility. So my view about ordeals as a mechanism for physicians is not an anti-rationing argument. I think it's just the wrong mechanism. And the test case would be an organization like Kaiser, which is large enough, it has 12 million members, to be studyable. They do not use ordeals, but it's a highly managed practice. They don't just say to physicians, do whatever you want, you're the king or queen of the roost. So in my own field, psychiatry, when for the first time there was a generic selective serotonin reuptake inhibitor, when Prozac went generic, they made an evidence-based decision that for first prescriptions, there's no difference between the existing agents. We should choose the cheapest one. So how did they manage it? They managed it by expectations and education. Why we should think we should do this, let's do it. And on the prescription pad, if I'm writing a first prescription and I'm checking a lot for Zoloft or Paxil and not for Prozac, I'll be called to meet with my department. And I'll say, Jim, perhaps you know something that we don't know. Could you please explain to us and teach us what you're doing? Now, if I had great evidence, that would be important. But if it's a preference, if I feel my intuition should overrule the evidence, I'm going to get embarrassed. Or at a certain point, they're going to say to me, maybe you're a good human being, but you're not the person for our practice. So hasta la vista.
Yeah. Well,
Two things. Before I answer Nair, I don't. Thanks. Before I answer Nair, I don't think it's usually possible to be an educated healthcare consumer, especially with respect to the purchase or choice of insurance plans. This is very, very difficult and not transparent. If you look at an array of a dozen potential plans, if you're fortunate to have an employer who might offer that many, it's very hard, not only that you can't predict the future and what your healthcare needs will be, but even given what you know your current healthcare consumption is, it can be very hard to figure out with the array of possibilities. So I think it's a real challenge. Someone's a new employee, HR sends them a list, they have a time frame, people worry about making a choice, they read everything they can get, and even then, it's a challenge. So I think that's a challenging area, and an area where some work on transparency would be helpful. As far as the issue of doctors' expectations, regarding income or lifestyle or whatever you want to call it. The doctor in a small practice may in some ways have more of an opportunity if they're independent of an organization to choose to do less. But even in those cases where what we are seeing, people are doing less patient encounter hours, they're making, in some cases, less money, or when or they're shifting, students have shifted over the years in which specialties they choose to do, and they're choosing the much more remunerative specialties, the top students are, which they hadn't all chosen in the past. So they're making those decisions. But even then, there's still overhead. So when you do something that costs the doctor 10% of their revenue, that's 20% of their revenue because half of it is overhead. So if they try to reduce things, they're going to run into certain problems. But more and more physicians don't even have that choice, right? They're working for an institution, even the so-called nonprofit, the massive entities we have here in Boston and around the country, basically operate on very short-term, quarterly profit business principles, not just quarterly profits, but imaginary budgets. They say, this is the target we want. You just need to see another 5% more patients and we can hit the target. And if you don't, and that's each year sometimes, and if you don't, we're not really, you'll lose pay, but at a certain point, not only will you lose pay, we'll hire somebody else. We don't really need you to do this because we have a bottom line here in our business. And unlike the idea of a family, which, you need to budget in a business-like manner, but your family isn't a business, and you make certain distinctions. We think healthcare does it that way, but they do that less and less, and now they're operating more and more like corporations that are free market corporations making a product, and the insurance industry is doing the same. The insurance industry isn't interested in healthcare. It's interested in what kind of earnings you can make on large amounts of money to a great degree. At least that's my impression. So I think these are challenging sort of ways to manipulate the system. I don't think it's simply a matter of, you should earn what doctors in Europe earn or something like that. It's much more complex than that.
Why don't we open it up to everybody? Anybody who'd like to make a comment? Jim?
I just wanted to comment that we've talked a lot about how ordeals and convenience can be good for allocation, but they're clearly second best in that they impose this dead weight loss. And so in terms of practical implications, I would think it would be very useful to try and think of ways to get the allocation while minimizing the dead weight loss part of it. So Richard suggested you could have the village build a storage shed. Like while people are waiting, they could do things that are useful, like answer surveys on SurveyMonkey or something.
But Richard said they didn't need the storage.
Well, I was
I
giving an
understand
extreme
that,
case.
but maybe there's something they do need instead they could
yeah.
build instead. But sort of open up the box to thinking about ways. The primary concern, I think, is that we don't want to allocate things by money because money is so unequally allocated in society. So one thing you could have is artificial currencies that are useful in certain markets, like for healthcare. So people, you could allocate these uniformly in the population or however you want. And then people can use them to express their strength of preference for the particular treatment or whatever it is. But there's no dead weight loss associated with that because is not this just deadweight burden. So I'm not sure that the artificial currency is actually good in healthcare or not. But I think that's, just imposing burdens to get allocation is at best second best, and maybe we can find better ways to allocate.
Thank you. Chris?
Well, I think we've already talked about how cost exposure can be scaled to income to solve that, the prima facie problem there. Another solution related that I've been working on is indemnities as a form of insurance. So rather than making another currency, we can actually just pay people in cash. So keyed to, if you get cancer of a certain type, here's the size of your indemnity, and it happens to be enough that now you can afford the off-label chemo drug, or you can instead spend it on something you prefer. And so we recreate a price mechanism, and there's issues there if the insurer isn't able to observe the actual severity of the illness to scale the indemnity appropriately. But at least in principle, some of this can be done with good old-fashioned cash. The other thought is, to go to the other piece, is how can we make these ordeals less wasteful? You mentioned the survey, completing surveys while you wait in the doctor's office. I've been working on a similar project with jurors, and whether we can use them for doing mock jury research to help settle cases while they're waiting to potentially be put on a real case. And so I don't know what the analogy is for patients, but I actually have done other studies where I recruit patients in waiting rooms. But I imagine, I don't know how much opportunity there really is there to generate data. But we actually do need a lot more social science data about healthcare, so maybe that's an opportunity.
Yeah.
I'm intrigued by Jim's suggestion. I'm thinking, just gonna play devil's advocate just to move the discussion onwards. I can imagine the following complaint. While the deadweight lost ordeal was like, not ideal because it's wasteful, this thing that Professor Hammack is now proposing to us is exploitative. So we're talking about, unlike some people who want the expensive drug just because they're vain, I need the expensive SRI because of my very particular type of depression, which is not responsive to other SRIs. So I have bad luck, and it's unfair that I'm worse off or that I'm unlucky in that way. And you're exploiting my vulnerability in order to promote something which is actually of value for society, namely building this building which you want built, or fulfilling any other goal of real value. And that's very close to the definition of exploitation. You're preying on people's unjust disadvantages to achieve something which you want, perhaps for good reason, because it's good.
Yeah.
Isn't it also exploitative for you are more willing to suffer the pure deadweight loss burden than I am, so I'm being exploited, and that you'll get the good because you're more willing, I'm less willing to tolerate that than you are.
I don't think that would be an exploit. He's not exploiting you. He is taking advantage of the difference in toleration of this thing, but
So that's unfair to me, because I really hate listening to the stupid music in the waiting room.
So another way to
Even though I really need the better drug, I just can't tolerate this music in the waiting room.
I think that's analogous to, in cost sharing, you being poorer.
I mean, that generalizes the notion of exploitation to cover almost any transaction.
Can I, another notion of hybrids, you talked about these tokens, for example. I mean, you could use in this example of physicians, you could allocate each physician a base rate of these expensive off-label prescriptions per year based on our big data approach as to what we would expect your case flow would generate. And then only impose the true inconvenience if you use up your tokens. So you can get more tokens, but now you have to make that annoying phone call. So hybrids like that could potentially reduce the net deadweight loss if we had a decent prior assumption of what's the appropriate use rate.
Although ordinarily you'd assume that a lot of people wouldn't have the average number, but now that they've got these chits, they might. One observation about your indemnity thing. All right, so now if you're paying out cash, there are going to be a lot of people who say, avoid suffering or get money. Well, they need money a whole lot. So now they're using, they would be turning away from the health good to other kinds of goods. All right, it may make a lot of sense for them, but this is a healthcare system,
Dan, are you a health essentialist after all?
No,
I thought you cured yourself of that long ago.
Of the system, suddenly you're flooding the economy with these health dollars, but they're supposed to be earmarked health only.
But that's welfare destroying.
Maybe.
Can I have that
Part of a
economist
larger
quote?
argument.
Yeah. So I just want to make a suggestion for the doctors in this room, by the way, some of whom seem to me to be pretty senior and not burnt out. So I'm glad that we, the ones who were burnt out, didn't, and are coming to this conference, which is unbelievable.
Although I think some of them are burned out.
And that's the only reason that they're here.
Well,
Some
for
came
comments, they came
some
here
of
in
them
order
came for
to
the free
let
food.
off some steam
But
after
I
the
just
burnout.
want to make an observation. I believe that some of the reason why there's so much waiting time in the healthcare system is our time as patients is so unimportant relative to your time as a doctor.
Yeah.
So we may as well stack up 6 guys just so that you never have to have a spare moment if you don't want a spare moment. And one of the things that's always puzzled me, and I think would be easily correctable, is making the doctor's waiting room somewhat less unappealing. For example, I praised Harvard University Health Services yesterday. The magazines, in their thing, I feel like offering, say, I will buy subscriptions to Sports Illustrated, People Magazine, and things like that, rather than things like Nutrition Today, okay, which nobody wants to read. I only know of one medical office where there's a computer terminal that you could use while you wait. I don't think this would cost the doctor all that much, and they might be able to do that. I guess televisions in waiting rooms are verboten. I don't know why.
They cause
And-
disutility to people like me.
I understand you and Neera, who doesn't like music, wouldn't like it. But what I'm saying is we could try and make the experience a little bit better. I am willing to pay, for any doctor in this room, I am willing to pay for their subscription to Sports Illustrated and to People Magazine. Okay? Just to make their patients have a better time while they wait for the distinguished physician at the, fancy Harvard hospital.
Well, here we should get the New Yorker and the New Yorker Review of Books.
No, I understand, but that's a little too elevated for me.
Okay. Yes, please.
Hi, again, forgive my my limited knowledge of the system and the process in this jurisdiction, but to me, my limited knowledge suggests that medical care is about minimizing human suffering and preventing premature death. And I think that that is a very sacred profession. I believe it's one in which a patient and a doctor have a special relationship, and medical professionals are supposed to operate and work within a strong degree of professionalism and use technical criteria to establish whether whatever treatment care is needed. I'm a little bit concerned about external stakeholders being party to that decision that could affect somebody's lives. So I would want to suggest that maybe insurance companies and all the other stakeholders can focus a little more on promoting effective promoting health promotion and optimizing people's well-being in such a way that they don't need to actually waste a lot of money in terms of dealing with medical care and all these other type of things. So my suggestion is very simple, but that's how I am seeing it. I hope you could.
Matt, Dan?
Yeah, go ahead.
Yeah.
So I think for the reasons Dan explained earlier, this idea that there are external stakeholders and internal stakeholders, I think, is a false dichotomy, because we are all payers, whether through our taxes or through our insurance premiums or through our lost wages because our employer paid our insurance premiums in the U.S., that I think we all do have a fair stake and a fair say in how the system will be constructed. And so I have a say in whether Johnny and his Dr. Jones waste health care or not, because I'm going to pay for it.
Agreed, I believe, but the actual, if there is supposed to be delays with respect to accessing particular medication and so on, that to me is a medical decision, and it shouldn't be based on someone external to that deciding that. If medical doctors or the fraternity, there seems to be a breach of proper protocol procedure and in terms of the diagnostic criteria, whatever it is you use, then that should be reviewed by the medical professionals or whatever body that oversees their practice. But I'm a little bit, and this is from an external, I'm not from here, so I'm not, it's just that I'm a little bit concerned about other people who are not really in tune with the day-to-day medical issues imposing a decision in that. That's my concern. That's my main concern. I am not claiming to have a solution. I just throw that out.
I hear you, but every medical concern is also a economic concern, and every economic concern is also a political concern. So I very much see we need to be careful not to override clinical judgment. On the other hand, these are economic questions.
This is where the issue of reins and fences comes in. The external stakeholders, through taxes and other mechanisms, are involved with how much money is available. Once that has been established, I think you're right. It's the management of those funds is best done by the community of physicians and patients.
I disagree.
Reins, what we have in the United States, I hope you don't have this in
Yeah, we
Tobago.
don't have ours.
What we've had in the United States is a system where we've tried to manage the economics by reining in what the physicians do, rather than by saying to them, and their patients, here's the budget, here's what we have. Make the best use of it you can to alleviate human suffering.
But there's a third element that I think is not apparent at first view. Some years ago, there was a series of studies done at Dartmouth Medical School on clinical judgment. One of the most famous ones was they took a bunch of patient records to some pediatricians and said, "Do you think this kid needs to have his tonsils taken out?" And they in a certain percentage of cases, they said yes. And they took the ones that they had said no to and took it to another panel of physicians and said, "Do these kids need to have their tonsils taken out?" And the same percentage was, they marked yes, take his tonsils out. Then they took the remainder of the ones and they took it to the third panel and the same. So over and over again, it looked like the physicians would look at it at a sea of these charts, and they had a rate in mind about what percentage of kids needed their tonsils out, and they would just apply the same cookie cutter to every sample. And then they did it again and again and again in one kind of a very important decision after another. And that was a kind of fulcrum. The debate over whether external voices need to be part of the picture, it was totally transformed and has remained that way. It's just unfortunate, but that's the way it is.
Yeah, thank you. In my classrooms when I'm teaching, I use comparison of different models around the world. So certainly I will take the knowledge. Thank you.
Can I just make a comment about this?
Yeah.
An awful lot, we keep thinking that all the decisions on whether we use resources now or whether Dr. Sabin and I decide whether I should get such and such, whatever else it is. So many of the decisions are made far prior to the time that I get into his office. We subsidize medical education. We subsidize the building of hospitals. We prevent people from having certain types of medical technology. We encourage doctors so that we have duplicative medical technologies. And so it's not as though, Dr. Sabin sort of says, "Oh, my patients are coming in. I think I'll go to the health supermarket and buy the materials that I need." I mean, already we've substantially pushed and pulled and encouraged and discouraged the types of resources that he's going to have available.
To some degree, even which ones will be invented. I mean, you can roll that clock further back.
Peter, last word, because we're actually out of time.
I know this is like this broader health systems discussion, but I think, basically, even though we don't like to say so, all advanced countries and many emerging economies have socialized both the costs and benefits of the healthcare system in various ways, many different ways. But the issue is really not, are we doing that? I think we're doing that. The question is, how are we doing that, and who's bearing the burden, and who's getting the benefits, and so on.
And how can we do it better?
Yeah, how can we do it better, right.
So I guess we're not going to conclude, and I was thinking, is there any way to avoid the pun I'm about to use? And I thought, no, there's not. This has been far from an ordeal. And again, thanks to the organizers and to the staff.
Thank you. Thank you, colleagues, gentlemen.
That was fun.
It was.
Thank you for having me.
Okay, Jim,
you for-
good to see you.
Yeah.
Stay well.
What are you guys doing?
Get killed talking about.
Right, you were saying
Right. Right.
Well, we've already found a place. Thank you, though. I would never hesitate
Why
to
we
offer.
should?
Thank you.
Yeah, I think that, no, there's not a good reason. Where might you go
No, this study I get.
to first get condiment and loss of earth and that sort of stuff.
Still, but I'm a little bit.
Yeah.
Barbecue or something. Let's take over on down on.